Good morning, dear friends. I'm Ayman Fakhry, Israeli from President. I'd like to thank Natalia Cardozo for organizing such a very big event. And I'd like to thank your friend, Professor Sergio Jansini, for inviting me to talk about this nice presentation, talking about treatment in recognition of venous compressive syndromes. I don't have in disclosure. Venous compression syndromes are about two disorders characterized by anatomical extension compression, typically in young and healthy individuals. By uncommon, they may cause serious complications, including pain, swelling, deeper thrombosis, polymorphism, and PTS. There are four main categories: May-Thurner syndrome, profunda syndrome, venous TOS, and portal vein compression. I'll talk today about the May-Thurner and the venous TOS. Venous TOS, approximately 4,000 patients have been included in the literature since 1970. 50% of these patients underwent declotting surgically of the subclavian vein thrombosis. The compression in 18%, while endovascular treatment 15%, and conservative treatment 15%. So this is the endovascular thrombectomy system for acute subclavian vein thrombosis in severe venous TOS. As you see, this is the venous thrombosis of the subclavian, and this is after recanalization and the thrombus removal, and this is MRV 3 months follow-up. This is another very interesting study about the use of IVUS in the management of venous thrombosis. And as you see, this is the thrombosed vein after recanalization and stenting using IVUS was proper deployment of the stent. Iliac vein compression, traditional surgical treatment of May-Thurner syndrome is outdated. Endovascular treatment of DVT caused by May-Thurner is both feasible and effective. Angioplasty, stenting, selective thrombolysis are now the standard treatment for the symptomatic May-Thurner. However, there has been no agreement on treatment of IVC. This is a very nice paper discussing the long-term outcome in endovenous treatment of acute lower limb DVT combined with May-Thurner syndrome. And conclude that endovascular treatment of acute lower limb DVT with May-Thurner syndrome has good overall efficacy. And younger patient with DVT caused by multiple factors beside May-Thurner syndrome, prolonged anticoagulation and close follow-up may be more appropriate than primary stenting after thrombus clearance and significant relief of lower limb symptoms. Another study done in Pittsburgh talking about the clinical case of successful endovascular treatment of obstructive PTS in lower extremity with balloon angioplasty without stenting, and conclude that plain balloon angioplasty as a standalone method for treatment of obstructive PTS in the lower extremity with long-term follow-up of patients is crucial to determine if the decision to avoid iliac vein stenting was clinically justified in such patients category and whether or no long-term anticoagulation can be preserved the clinical outcome of the conducted treatment. But nowadays, the updated and standard treatment, this is the occluded thrombosed common iliac vein after thrombus removal using IVUS to determine the compression and balloon angioplasty with atlas balloon. As you see, this is the compression. After angioplasty, still there is a residual compression, and after stenting with nice flow to the IVC. We have to, after this procedure, we have to check if there is residual thrombus or tapering of the iliac vein. This factor may invite further recurrence of thrombosis. Thank you, and I wish to see you again, and have a good day. Thank you.